frankly, all states. We are all working on issues around the cost and the delivery system, et cetera, all the things that you're hearing here. I said at the session earlier, the first session that Jim hosted here, who has the incentive to control the cost? We almost got a cost-plus system here, that nobody seems to have an incentive to control the cost. At the end of the day, the person that ought to be controlling it is all of us, and as individuals. And part of the problem has been there hasn't been enough of a buy-in and enough of incentive for individuals, because the data I've seen, 75 to 80% of the cost of health care is disease that is preventable, or the onset preventable or delayed, if people took more responsibility for their own health care. All of the issues around wellness. And I know this is long term, but we got to get at that. One of the things we've done in our little state, for state employees, put in place a $500 credit off of their share of the health care premium if they do certain things. Fill out a health assessment form, go see the primary care physician at least once a year, get in a weight management program, smoking cessation, whatever it is, a whole series of these things. The only way we're going to lower utilization, all right, as we age, is to have people take better care of themselves and be incentivized to do that. And I think the biggest incentive for people is they see some money in their pockets, some savings from doing that. Nobody wants to be sick. We know that. All right, that ought to be the incentive. But we've gotten used to, as a nation, that if we get sick, we got the best system in the world that's going to make us better. And what we need to do is change that mentality to say we need to do things as individual citizens to take better care of ourselves and hopefully delay. And then we need the system to support those kinds of things, the management structure, if you will, to support the kind of care that's necessary. That's the only way we're going to drive utilization down or slow it down, if we will. And that's one of the key drivers here in terms of what's pushing the cost up, as well as the cost of the system.
It's a very important point. And I guess it was, we did a special on this at CNBC, and one of the attendees said that an obese person will cost a company 4 times what a smoker will cost the company, because that person may develop heart disease and diabetes. So it's the incentive program is certainly what we're all talking about. Governor Rendell.
Yeah, I want to go back to what Haley said. At the risk of losing my card as a Democrat, I want to agree with Haley. He's dead right. We have no choice but to deal with the entitlement question. And the only way we're going to deal with it is if somehow, some way, and maybe it's the commission that the president's going to appoint, if we can deal with it without getting it into the political system. If you look at the current debate, the president's plan says it will save $500 billion out of the Medicare system over the course of time. And that's been turned into a political football. And yet we all know we can and should reduce entitlements to some degree. And we've got to get away from the politics of this game, or else we're never going to solve this problem. And it has to be Republicans and Democrats standing up together and saying to the country, look, we don't agree on a lot of things, but this is one thing we know, and we have to do it. And is there going to be some pain to it? Gosh, in the last 2 years, everyone at this table has administered a lot of pain to their citizens, not because we want to, but because we had no choice. And we've got to get down to the business of making real decisions for the country that are going to set us on the right path. And we've got to have people willing to accept a little bit of political peril, or else we're in big trouble.
I think we all agree. Governor Bredesen.
Yeah, just to add to what Ed said, this all is happening today in the context of things going on in the Congress. I mean, this is not a discussion in a vacuum here about what we might do about health care. There have been some of us who have been working on trying to put together some common stuff. I mean, Jennifer, you railed off a long list of things we all could agree on, but it was our experience we couldn't agree on them. I think Mike would agree with that. And I'd like to just, with Jim's permission, I would like to just ask people, are there things of this group around the table, are there messages that we could send as the NGA about, as you consider this, we're the ones who've got our feet on the ground and out there and trying to actually run these things, that we could inject into the discussion?
Phil, Over here, Maria.
Yes. I'm sorry.
Phil,
My apologies.
I really do believe that we have done that if you'll just take a tape of this program and send it to every congressman and senator's office. You're right. When we get into a setting that seems to somehow inject politics in it, like what Ed was talking about, we seem to find that we don't have as much common ground as we thought we would. When we're here not talking as Republicans and Democrats, but talking about the specific progress in our respective states or the plans that have worked that have been emulated by other states. And then when you listen to Jennifer tick off the list that she ticked off that saw virtually all the heads around the room nodding, and when you get Ed and Haley talking about agreeing on something, it really does, I think, illustrate the fact that governors, and I hate to be too prideful of my colleagues and of this organization, but governors have to solve these problems, really, and balance a budget. And they're doing it in virtually every state, a little bit differently from time to time, and learning from each other and setting a pattern which should and could be followed. There's very little rhetoric in all this stuff that's been discussed here today. There have been specific examples of programs that worked that did two major things. One, helped contain costs. And two, at the same time, as Jim pointed out, or maybe it was Governor Lynch, it actually improved quality at the same time. I mean, you talk about something that's actually ought to be transported into the minds of policymakers on the federal level about things that are going on in the respective states that do work. This program and the examples that have been cited here are things that really do matter and really do create solutions. Are they all perfect? No. And will they all work in every state? Of course not. That's why everybody keeps talking about flexibility over and over. But the fact that the examples that have been pointed out here are real solutions to real problems and starting down a road toward changing the paradigm, if you will, of the delivery and cost of the healthcare system are things that aren't unreachable, unapproachable, unagreeable. There should be no serious contention that partisan politics will be able to derail this. Maybe you just have to do it in a different forum or in a different focus where it's not in the middle of an election year, although that seems to be going on all the time now, where it's not in a forum where people are divided up but on one side of an aisle or on the other side of an aisle. But the solutions that have been talked about here, the specific examples of workable programs have been uttered by Republicans and by Democrats and have been copied by one another for the last several years, and they do work. So yeah, it can be done. I think it can be done. I think we've got a lot more agreement than we have disagreement if we just stop long enough to listen to the litany that Jennifer and that Tim both said a while ago were things that they thought most folks could agree on. And governors do it.
And we do need to get that list of successful examples to the Congress to show what has been working. And by the way, in addition, get that information to the people. Somehow this should be communicated to the country so that people have a better understanding of what works and what doesn't work. Because some of this stuff is not brain surgery. I mean, some of it is very complex. But other things people can understand and they can get behind. But this whole sort of notion of it's just too big to fix and it's just too problematic, you know, people get upset and they think they don't understand it, they'll never get it, and then it's over their heads, and then they just don't want to talk about it. And so it's a problem. Governor Manchin.
You know, the thing that maybe polarized things, expansion of Medicaid. Since Medicaid came into being in '65, it was never mandated. None of us have ever been mandated to give Medicaid to everybody just because you fall below the federal poverty guidelines. A lot of states can't afford it. But we've always had to balance our budget and live fiscally and be responsible. Now that saying we're going to 133, 150, whatever, really got everybody to say, okay, now you're going to mandate us that we cover everybody, which we all want to. And I don't think a Democrat or Republican doesn't want to cover everybody. But if you make us give the same type of service to an unfortunately person who is financially challenged but very healthy as someone who's financially challenged but very sick, that's very costly. That's where we keep talking flexibility, flexibility, flexibility.